Hello everyone, welcome to my video channel. Today I am going to discuss regarding a femoroacetabular impingement FAI in part 1 video. In this video, I will cover regarding the definition of femoral acetabular impingement FAI, 3 types of FAI, that is pincer type, cam type, and lastly mixed or combined impingement type. History and clinical examination that the patient usually present to you. What are the radiological investigation that will help you in diagnosing a femoral acetabular impingement FAI? What is a false profile view, crossover sign? What are the added benefit of CT scan and MRI in femoral acetabular impingement? Before we start, there is a disclaimer, and the disclaimer is the same in all my videos. Thank you. Now let's begin. Anterior acetabular impingement or femoral acetabular impingement FAI is one of the major etiologic factors in the pathogenesis of the hip arthritis. Definition of FAI, femoral acetabular impingement, is it is an impingement between the head-neck junction of femur and acetabular rim during functional range of movement (ROM) of the hip due to anatomical variations in the hip. Articular pathomechanics result in clinical signs of hip dysfunction and can mediate articular cartilage delamination, acetabular labral disease, and progressive secondary joint deterioration. There will be a formation of bone spurs around the femoral head and/or along the acetabulum. This extra bone causes an abnormal contact between the hip regions and prevent the hip movement smoothly during activity. Over time, these mechanical abnormalities in the hip joint resulting in inflammation, in tears of the labrum, and the breakdown of articular cartilage that leads to osteoarthritis (OA). Pathophysiology of femoral acetabular impingement is whereby the mechanism of injury is due to proximal femur abuts the acetabulum during the range of movement (ROM), especially during flexion of the hip. The pathoanatomy of the femoral acetabular impingement, it depends based on the types of femoral acetabular impingement FAI, whether it is A, a pincer type, B is a cam type, or C is a mixed or combined cam or pincer type. Again, that there are 3 types of femoral acetabular impingement: the pincer type, the cam type, and the combined pincer and cam impingement. For A, the pincer type, it is an acetabular-based disorder. It usually seen in an active middle-aged female. It is an anterior-superior rim overhanging, especially at the anterior superior quadrant. In pincer type of impingement, there is an acetabular retroversion, acetabular protrusion, coxa profunda, and coxa vara. The asterisk mark shows all of it is due to acetabular overcoverage. In pincer impingement, the femoral neck impinges on the prominent acetabular rim during the hip flexion. Repetitive microtrauma between the femoral neck and acetabular rim may cause the multiple cleavage planes within the labrum, leading to labral hypertrophy, intrasubstance cyst formation, calcification, and labral degeneration. Acetabular labral ossification further deepens the acetabular socket and increase the acetabular overcoverage. Acetabulochondral injury occurs in a narrow circumferential band at the anterior and superolateral acetabular rim where the force transmission is the highest, and as a contractile lesion in the posterior capsular labral junction by a distraction force. Due to the femoral head levering out of the hip socket with continued hip flexion. The contractile injuries tend to be larger in pincer impingement rather than Cam impingement disorder. Next, for B, I am going to discuss regarding the Cam type. It is a femoral-based disorder, mostly occur in a young male athlete. The defining characteristic is an abnormal osteocartilaginous prominence located at the anterolateral femoral head-neck junction. The deformities cause a reduce in the femoral offset, a reduce in the head-to-neck ratio, an aspherical femoral head, and presence of the femoral neck retroversion. This can be due to the previous slip capital femoral epiphysis, SCFE. In Cam impingement, the normal smooth arc of motion between the femoral head and acetabulum is disrupted due to the loss of the femoral head-neck junction concavity. As the aspherical femoral head is forced into the labrum during the hip flexion, compressive and shear stresses at the labral articular cartilage junction push the labrum towards the capsule and the adjacent articular cartilage into the joint. Hip chondral injury may range from fissuring to complete delamination and usually precedes the acetabular labral tear. Labral tears usually occur to the weaker 1 to 2 mm transition zone between the articular hyaline cartilage and labral fibrocartilage. Labral tears usually associated with articular cartilage delamination, and articular-sided labral tears are more common than the capsular-sided tears. As illustrated in the right-hand picture, there is an anterolateral impingement lesion with an ossified labrum. For C, the mixed or combined Cam and Pincer type, with both of these deformities, it forms around 80% of most cases of osteoarthritis. The impingement can occur due to too broad femur or neck or head, or the broad overhang from the acetabulum edge. This will lead to the labral or cartilage destruction and tears that will lead to early secondary hip osteoarthritis (OA). What are the signs and symptoms of femoral acetabular impingement (FAI)? Patients usually presented with the groin and hip pain, especially more prominent during the motion of the hip, especially in flexion position. Femoral acetabular impingement may be associated with buttock or lower lumbar symptom. Patient can also complain of mechanical symptoms, example, locking, catching, and giving away, suggestive of an acetabular labral tear or articular cartilage delamination with unstable articular flap. Patient also can present with symptoms of gluteal or trochanteric pain due to aberrant gait mechanics. Hip symptoms are more often activity-related and insidious in nature. Activities such as putting on shoes and socks, getting in and out of the car, or prolonged sitting may cause hip pain and discomfort. Any previous history of hip disease, trauma, or hip surgery is important and may be the inciting event. During examination, you will find that the patient has difficulty in sitting down, and in early femoral acetabular impingement, the gait is normal. Antalgic gait would occur with the progression of disease. Clinically, the hip abductor strength is weak. then there would be a positive Trendelenburg test. Flexion will be less than 90 degree, especially with an internal rotation, IR of less than 5 degree. Usually, remember the both hip is involved. Anterior impingement test, FADIR, flexion, adduction, and internal rotation will be positive. During inspection, you might notice an externally rotated extremity due to the post-slip capital femoral epiphysis deformity. For radiological investigation, the recommended views for radiograph include 1. Anterior posterior AP with true lateral. The hip is placed in 15 degrees of internal rotation. Another optional views include number 2, Dunn or modified Dunn view. Dunn view is taken in patient in supine position with the pelvis in neutral rotation. The hip joint is flexed 90 degree and abducted 20 degree while the pelvis remains in the neutral rotation. On the right hand picture, it shows the Dunn view. Number 3, a false profile view. This view is to assess anterior coverage of the femoral head. Patient will be in standing position with an angle of 65 degree between the pelvis and the film. Finding in the radiograph which shows asperificity and contour of the femoral head and neck. Pistol grip deformity indicates a cam impingement. As shown on the right-hand picture, it shows the false profile X-ray with an angle of 65 degree between the pelvis and the film. For the left-hand picture, it shows the pistol grip deformity that indicates a cam impingement. Another radiographic view is number 4, the crossover sign. Usually will be seen in a acetabular retroversion in a pincer lesion. It will show the anterior and posterior edge of acetabulum cross each other. There will be a posterior wall sign. In this, we can view the presence of acetabular protrusion, acetabular retroversion, and coxa profunda. In radiograph, measurement involved include A. Alpha angle. Alpha angle A is measured in a frog leg lateral view. One line is drawn connecting the center of femoral head to the center of femoral neck. One line is drawn connecting the center of femoral head to the anterolateral femoral neck, that point at which the head loses the spherical nature, whereby there is a prominence that starts there. If more than 42 degree, it shows the neck offset deformity, as shown by this picture. Okay, you guys understood? Okay, let's go to the next angle. B. Head-neck offset ratio. We measure in the lateral hip view. It involves a 3 line. The first line is drawn through the center of the long axis of the neck. The second line is drawn along the anteriormost point of the lateral neck, parallel to the first line. The third line is drawn along the anteriormost border of the head, parallel to the second line. The distance between the second and the third line is divided by the diameter of the head. It is the ratio that we want. If the ratio is less than 0.7, it indicates cam deformity. As illustrated by the picture, I highlighted where is the first line, the second line, and the third line in the illustration. So, additional radiological investigation, that is example CT scan of the hip and pelvis. Indication of the CT scan, it can be used as an adjacent or adjunct to assess for any structural abnormalities. as in a 3D reconstruction that will aid in the preoperative assessment. For MRI, magnetic resonance imaging or magnetic resonance arteriogram, it is the best modality to evaluate for articular cartilage and labral damage. We can assess anatomy of the femoral head or neck junction abnormalities. The findings in the MRI, it will show a labral frying or frying test, chondral damage, subchondral cyst formation. Yay! Finally, we are at the end of our video. I hope you have learned something from this video. See you in the next one. Bye.